welcome to our community, Our Health. This is a town hall series that is devoted to bringing researchers and the community together to share ideas and facilitate conversation. Today's event will focus on colorectal cancer prevention, and we have a great panel of different researchers and research coordinators that will be discussing some of the work we're doing. We'll talk about barriers, some barriers that communities experience related to getting screened for colorectal cancer. We will share some resources and information about how to participate in some ongoing research studies. And our panelists today will discuss various options about cancer screening, as well as share information about nutrition and the microbiome. And we'll have a brief section on how diet may impact the prevalence and trajectory of colorectal cancer. My name is Dr. Melissa Vilaro. I will be moderating the panel today, and I will also briefly present some of my own work related to colorectal cancer as a panelist. And then just a little bit of background information about myself. I'm a postdoctoral associate at the University of Florida STEM Translational Communication Center. And I hold a PhD in public health and a master's in public health. So a lot of my research is focused on developing culturally sensitive behavior change interventions to promote health among diverse populations. So I'm really excited to be here today moderating this discussion. And I just wanted to quickly thank our community, Our Health series is conducted by the University of Florida's Health Street program, which is located in the UF Department of Epidemiology, UF College of Medicine, UF College of Public Health and Health Professions, and is funded by the UF Clinical and Translational Science Institute. So thank you for all of those organizations for bringing us together today. Before we begin, just a couple of housekeeping things. If anybody has any questions, there's a Q&A button at the bottom. Please feel free to type any questions you have throughout the session. We will either type our answers into the chat, and we will also have about 10 minutes at the end of the session for the panelists to answer any questions. So please use that Q&A feature. And we'll be moderating those throughout. So without any further ado, I am going to welcome all of our panelists and turn it over to them, each of them to introduce themselves. And we have a couple, about 3 minutes for introductions. So please go ahead and introduce yourselves, panelists.
Yes. Thank you, Dr. Vilaro. I'm going to start, everybody. Hello, my name is Eric Cooks, and I am a postdoctoral researcher at the University of Florida's STEM Translational Communication Center. And my research focuses on the use of virtual human technology to increase colon cancer screenings. So yeah, I'm very happy to be here and very happy to speak with you all about this very important topic today.
I can go next.
Yeah, and you can just kind of jump in and introduce yourselves.
Excellent. My name is Miriam Buhr, and I'm a research coordinator at the STEM Translational Communication Center at Weimer Hall, and we're working on a clinical trial of looking at screening, colon cancer screening. I work with Pedro and some of the panelists here, so I'm happy to be here and discuss.
Great, thank you, welcome. Pedro, would you like to?
Absolutely, yeah, my name is Pedro Elizastegui. I'm also a research coordinator here at the STEM Translational Communication Center. I work with Eric and with Miriam here on the project of utilizing virtual healthcare assistants in order to help people get screened for colorectal cancer as well.
Great. And
almost look like a family reunion here. So I'm Christian Jobin. I'm a professor in the Department of Medicine. I'm not a physician, PhD. My team works on microbiome that comes from different organs, especially in the gut, and how they could influence your health with a specific focus on colorectal cancer. Looking forward to the discussion.
Great. That sounds like we'll have a lot of diverse perspectives and experiences as they relate to colorectal cancer. So I think this will be a really interesting panel today. So we can just jump right in because I think we'll have a lot to discuss and a lot to cover. And I'm going to turn it over to Dr. Cooks, who will lead our first segment and discuss just some of the background information about colorectal cancer and why we are here discussing this important topic today.
Sure. Thank you. Yeah, so I'm just going to give a brief overview in terms of kind of describing the gap that we see in colorectal cancer screenings among minority groups, and then getting into talking about ways that we can potentially bridge these gaps. So colon cancer is the second leading cause of death in the United States, and racial and ethnic minorities are disproportionately represented in terms of new cases and in the number of deaths. So there is evidence that shows that getting regular screenings does improve the likelihood of catching colon cancer early and to ultimately being able to survive. Yet minority patients are getting screened at lower rates, meaning that their conditions are being diagnosed at more advanced stages, and they're more likely to have worse outcomes. In particular, during COVID-19, what we're seeing is that rates of screenings are going down across the board as healthcare systems are delaying non-urgent screenings. So in order to address this health disparity, it is important that we seek out ways to bridge this gap and to ultimately to get more people screened. So of course, the next logical question from that then is, well, why aren't people getting screened? What are the factors that are kind of driving these disparities that we're seeing? So there are many, 3 or 4 of which that I'll mention right now are cost, time, and invasiveness of the testing, and also the tendency for there to be a lack of knowledge about the importance of screening and the available options. So cost, the colonoscopy, which is considered to be the gold standard screening procedure, can be expensive, particularly for patients that are either uninsured or underinsured, right? For these patients, the procedure can simply be out of reach from a cost perspective. Also time, right? So a lot of patients that are in economically uncertain positions, they can't afford to take time off work. So there might be indirect costs that come from getting screened in terms of lost wages. And again, this can be a significant barrier for patients, right? So also the perceptions that surround the test. So there can be a lot of stigma surrounding the ways in which the colonoscopy is conducted. And this can serve as a barrier to people going out and getting screened. And again, as I mentioned, also just there not being, people not knowing the importance of getting screened, and the fact that there are different options for screening outside of just the colonoscopy. So those are just a couple of barriers. And during this talk today, you're going to hear about many more and some possible solutions. And our speakers are going to provide multiple perspectives on this. But just overall, just leading us in, I think it's very important for people to get screened. I think all of us think that. So obviously nothing new there. To get screened is important. But I also wanted just to make the point that it's also important that we get diverse groups of patients involved in research, right? So this allows us to get a more complete picture of what's happening within these populations. So, and that's really something that we're kind of lacking right now, lacking that knowledge from a diverse patient perspective. So that's also something that we want to work towards. So with that introduction, I will go ahead and introduce our second panelist, Dr. Jobin, who is going to discuss with you all gut health and the microbiome and talk some about his interesting work.
Thank you, Eric. Well, if you don't mind, because I'm not sure how much of awareness there is about the microbiome, so I thought I will just use 1 or 2 cartoons just to bring you on the same page. So microbiome is an integrated part of our body, right? So we have a defined number of human cells, but I have as much microbial cells. So in that sense, we are almost part foreign and part human. And this is just a number of cells. But if you think about genes that these microbes contribute to our own system, you will have this huge proportion of microbial genes here. Almost 90% of genes that form us are not really us. They are microbial derived. And when you think about health and diseases and the physician trying to alleviate and attenuate disease or prevent disease, a lot of focus is on these mammalian genes and not so much on the microbes. So we tend not to take them as on an equal footing for human health. And we should view ourselves as an interconnected network of mammalian cells and microbial cells and partnership. And if you understand that, we will pay a very good attention to our balance, this state of balance that we all seek. Because these microbes are not static. You will acquire them very early on in your life. As soon as you're born, you start popping up and assembling of microbes up until your full lifespan. And these microbes are under stress from environmental factors, genes of our own set of genes, inflammation, diet, and lifestyles. So all these factors we know influence cancer. So one of the integrated part of maybe risk, environmental risk and lifestyles and diet converge on the microbiome, and that tip that balance. So there's a lot of interest in trying to make the microbiome part of your strategy to maintain health and prevent cancer and many forms of disease. But I'm interested in cancer, and the focus of this panel is cancer. And there is a lot of interaction with diet, and the fact that we could intervene on microbiome makes it a very appealing strategy, because if you have a genetic defect, it's very difficult to correct the genetic defect. Maybe later on, but it's easier to manipulate your diet, probiotics, prebiotics, fecal transplant, and so on. Try to balance the microbes. So I'm looking forward to connect with you all and see how we could integrate this element component that we have all in our body, which is the microbiome, and how we could get this to link with a preventive maybe strategy of cancer. So that's my little awareness, and I think I have to introduce the next speaker.
Well, actually, before we move on, Dr. Jobin, this is really interesting, and I curious to know if you could tell us a little bit about, so if someone makes changes in either their diet or any other behavior, how long does it take to change the microbiome? So is this a long process, or is this something that takes weeks, months, years?
Right. Yeah, that is a great question. And there is data out there that shows that you could switch your diet. You know, if you do an extreme diet, so you're omnivore and you go to a vegan, let's imagine that you could switch that or flip that switch. You will see change in microbiome very fast, within the weeks, within days. You will see that change in microbiomes. But the microbiome change, if we think about number of microbes and how they look like, the change will be there, but the critical output of microbes is what they produce. So these microorganisms take our dietary that we don't use. We cannot utilize or ferment or digest them, and they pass. And we pass this residual food to the microbes that have the genes, and then they synthesize molecules. And these molecules, you will pick them up. If you analyze your blood, you will see a huge change in your metabolite output if you switch the diet. And so it is fast. The problem with diet, as we know, is can you stick to it for the period of time that will make you less susceptible to XYZ disease? And that's always a challenge of diet. But there is a form of dietary supplement that seems to be easier for people to do. popping a dietary supplement is easier than changing the entire nutrition habit. And these may be another way to get your microbiome engaged in a good behavior. A bad diet makes your biome producing compounds that are not healthy for you. And, you know, that's this balance I was talking about. So it doesn't take that much time to get it. The challenge is to sustain the change over the course of a lifestyle, of a lifespan.
It sounds like the microbiome is kind of like the middleman between what we do and what we eat, and then they're taking kind of the leftover
correct
components that our bodies can't process and
correct
promoting either disease or health. Is that kind of a good?
Yeah, no, you got it exactly. Middleman, an important middleman. So you need to treat the biome with care. You know, we think of you know, wellness and the holistic approach, and we don't view the microbes as an integrated part of that holistic approach. And it starts with diet. There is factors like stress, environment that may or may not be easy to control. If you live next to a you know, factory plant that has a lot of pollution, it's difficult. You know, do you relocate? But that environment is more challenging to manipulate. But your diet is somehow easier because it's a decision you make. So there's something about the diet that has a profound impact of microbes, and that middleman is an important player in your health. That's for sure.
Great, that's really interesting.
And actually, there's data out there for a diet switch of high risk African American. I think they were in Pittsburgh, Northeast, and they have a 10 times higher rate of colon cancer than rural African from Africa. And the diet obviously is quite different. We have a westernized diet with high fat, sugar, and everything that goes with that. And rural African had a plant-based, very high fiber, up to 50 grams of fiber that no one is having here daily. So they switched their diet from plant-based to African-American and burgers for rural. And after 2 weeks, they looked at the microbiome. They could see a dramatic change in the microbiome composition, but also molecules that I was talking about. Beneficial molecules start to be circulating in the plasma and in the gut of African-American. 2 weeks is not enough to change in cancer, obviously, but they could see when they look at their GI tract markers of good health. Mm. So that's another way, going back to your first question about how long does it take? It doesn't take that long to see a beneficial effect. So the challenge, like I said, is, are you going to stick to a 50 grams fiber plant-based diet for, you know, for the next 25, 30 years? And that's the challenge that people face.
Yeah, and that's a huge challenge, and that is actually, unless you have other things you'd like to say about the microbiome, that's a great transition into some of my research and work, which, as you mentioned, is the how do we get people to change their diet? So the behavioral part of engaging people in eating those healthy diets. And so I think that's a nice transition, because a lot of the work that I do is focused on trying to engage people with, you know, what are the risk factors. So when it comes to colorectal cancer, as you mentioned, you know, an overall healthy diet is really what we're trying to promote. And then specific to colorectal cancer, the nutrition guidelines, the scientific evidence really kind of focuses on 3 risk factors. If we just want to focus on what things increase your risk, we can talk about alcohol, red meat, and processed meat. So the scientific evidence around some of those specific foods is pretty good, that if you eat more of them, you're going to increase your risk at a population level. And if you can avoid or limit those food components, you can reduce your risk. And so the World Health Cancer Research Fund actually has guidelines that recommend that people who are trying to reduce their risk for colorectal cancer avoid alcohol, processed meats and limit red meats. And so a lot of what I do is try to talk to community members and people about how do you feel about these guidelines? How are you? So if we know that we're supposed to be eating lots of fruits and vegetables and trying to avoid some of these risk factors, and we know that, how do we actually translate that into a behavior that we can do? And so, it's one thing to have the guidelines and know that these are things we want to do and might try to do, but when it comes down to the behavior change, it can be quite difficult, because eating is more than just, we don't just eat for health. We eat to celebrate, we eat for social reasons, we eat, as you were mentioning, with the, cultural factors influence what we eat. And so trying to talk to people to figure out how can we communicate this message in a way that makes it seem like it's something we can change, or you can change in your daily life.
How do you address the social economic problems? So if you could target hotspot of prevalence of cancer linked to where they live, access to quality food, not food desert. So you could have a guideline, but if these folks don't have access to the proper, it's easy to stop taking salt. Maybe you salt less, but I mean, processed food, a lot of food comes already packaged with all these extra, risk factor. So going back to shopping on the aisle of, on the side of the grocery store, not in the middle, you have to have selection in your neighborhood. So how do we get to these behavior change if you don't have access to the proper food?
Right. And I think that's a great point, because it's not just an individual level behavior solution, right? Like, so the solutions do really have to be multi-dimensional, multifactorial. The particular project that I'm developing now and recruiting people for really does focus on just the risk factors. So it is a behavior change intervention. So I focus on alcohol, red meat, processed meat, because it is slightly easier to say, if you're eating these things, let's strategize ways that we can limit or avoid what strategies would be appealing and acceptable to you. So if you're drinking, one glass of wine a day or one beer a day, maybe you do every other day for a couple of weeks and see if you can limit and reduce that way. Or maybe you add some seltzer water to your beverage so it lasts longer, or add ice. And so we're finding strategies, small behavior change strategies for these risk factors to limit the risks. And that's kind of the focus of the project that I'm working on now. But you make a great point that, like, we also want to give people alternatives, right? Like, so if you're reducing the red meat and processed meat and alcohol, what are the alternative foods that you can eat, right? So we're promoting fruits and vegetables and healthy diets, and people need to be able to access those things. And so, there are a lot of kind of structural and access policy level interventions that can help with some of those things, and then talking to people to figure out what are your needs, what are your preferences related to those things, and working with community is kind of the quick answer is that there's not an easy answer to that, but it does have to be a multi-pronged strategy. So that's why I really like the team that I work with, because it does include people who kind of are looking at things from all angles.
Right.
So from the communication piece, what language are we using to describe the guideline, all the way up to, can they access the food or the test? And when it comes down to it, for colorectal cancer, even if you can't make those dietary changes, still the best way to prevent it is to screen. And so to stay within guidelines for screening, that's another way within the project that I'm doing, that we try to promote the message of, you can change these things in a healthy lifestyle, and that's one component of it. But even if you can't or don't want to change those things, staying within guidelines for screening and learning about the options for different options for screening, and talking to your doctor about screening is still really important. And even if you are doing all of those things, you still should engage in screening.
Right. No, that's a great point. Yes. They had a question about yogurt and other sources as helpful microbes. How does increasing these line up as productive relative to reducing processed meat, red meat, and alcohol. So could taking more yogurt counterbalance red meat? Then obviously you need to have a, take more of the good stuff and reduce what you think is deleterious, like a multi-step approach. But how much of yogurt will counterbalance 3 glasses of alcohol?
Yeah, and that's a question I get a lot when I'm trying to develop the communication piece with people. Like, well, if I eat this much, how much does my risk increase? And there was a study that just came out in JAMA that does add yogurt as protective, right? But I don't know that the science really does. It's not a relative like pro con. If I eat this much yogurt, can I drink this much alcohol? And so communicating that can be complicated too. But I think at the end of the day, when it comes to colorectal cancer prevention, the screening has to come as, even if you make all these changes, or even if you have a perfect diet, we still need to screen. But yeah, those are really good questions. And I think the science, there's really great research out there kind of pooling together a lot of different studies in nutrition. And I don't know the literature at the level of the microbiome, but just at a population level, there are some really good high quality studies out there that are trying to piece together what are the dietary patterns that are, lots of fruits and vegetables, reducing meat, it's kind of like those patterns, overall patterns of dietary intake are going to be helpful.
That below a concept. I'm always having fresh veggies. I eat that, after my breakfast during the mid-morning. I have my peppers, cucumbers, carrots, and now radish and everything. I eat that, and then when I go home and drink a glass of wine, I feel happy because I did something good. But this is a perception we have, like one good thing. Well, I could maybe have but obviously they don't negate each other. They don't counterbalance the effect of that.
Yeah,
and I wanted to answer the question actually.
Yeah, and it's important to know that like nobody has a perfect, diet. You know what I mean? Like just because the guideline says to avoid, that's the guideline. That's what's going to reduce the risk. And you get the other end of it is that you shouldn't beat yourself up if you're not there yet. Like if you eat 4 pieces of bacon every Saturday, try to eat 2 pieces, for the next month, and there make small changes, and though, over time those accumulate. So I don't know if we want to move on, or I could turn it over to Dr. Cooks, who I know is going to talk a little bit about some of the other barriers. So changing behavior can be really hard. And we don't have like the perfect intervention, but definitely talking to community members and people and asking them, what do you want? What do you want? What do you need? How would this be helpful to you? Helps me at least try to make interventions and messaging that people can relate to and engage with. So I'll stop talking about food and eating because I could talk forever about eating, and I'll turn it over to you.
That's interesting. Definitely, thank you. Yeah, two really interesting conversations. It's really cool to see how the different components of this kind of come together, and very interesting to hear some of the barriers to implementing healthy eating behaviors. And kind of building on that, I'm going to talk a little bit more about some of the barriers to getting screened for colon cancer. In particular, I'm going to talk about 3. So I'm going to talk about transportation, I'm going to talk about fear, and I'm going to talk about the prep that goes into getting ready for a colonoscopy. So starting off with transportation, so there can be logistical concerns that serve as a barrier to physically accessing a healthcare facility. So there might be some patients who don't have a ride to their appointment, don't have a ride to the specialist. They are not able to physically travel the distance that is required to get to their appointment, or they might not have somebody who is able to go with them to that procedure or to that appointment, right? So these things can serve as challenges that are going to complicate someone's likelihood of following through with a screening recommendation of that type. Another thing that you see oftentimes is fear or some hesitance surrounding the way in which the colonoscopy is conducted. So patients often feel a sense of embarrassment because of being exposed to a certain degree during the colonoscopy. There can also be cultural or spiritual beliefs that can kind of cause some concern there. And even with the home-based stool test that I'll talk about a little bit more, there can be concerns related to those types of tests and some hesitance to collect a sample or to handle stool in that manner. So those things can also serve as barriers. And thirdly is the prep for the colonoscopy, which again is considered to be the gold standard and what people typically think of when they think of colorectal cancer screening. So there can be some hesitation surrounding the bowel prep that is needed to clear out your system the day before the procedure, and this also is a significant barrier. So again, the prep takes place the day before, and your procedure is often usually the day after. So again, as I mentioned earlier, for individuals that are in financially uncertain positions, you might not be able to take off for 2 days of work, right? You might not have somebody that can help you for that amount of time. Family and other living concerns and situations can serve as barriers to individuals in these populations that we're looking at to getting them ultimately to get screened. And there's also concerns about the medication that people receive during the procedure, concerns about that as well. So those are just three other barriers that are really related to getting physical in-person access to colorectal cancer screening. But as I mentioned, the colonoscopy is not the only screening option, and there are effective tests available that can actually address some of these barriers that we're talking about today. And one of these is the FIT test, which can be done at home, and the results of those tests are then interpreted by the patient's primary care physician. And what this test does is it looks for microscopic blood in the stool, and it has actually been shown to be pretty effective in identifying colon cancer in patients that are at average risk, and it is more cost effective. So home-based stool tests such as the FIT test can help to overcome some of the financial and structural barriers that we see in colorectal cancer screening.
How much of the Cologuard, I mean, I don't want to think about market, but people selection of home kit. I mean, Cologuard has been advertised it seems every day, multiple times a day. So how much penetrance does it have for people that are refractory to go on a hospital colonoscopy traditional screening? Do you know that?
I'm sorry, I had a little bit of a blip in my internet connection. Could you ask that one more time?
Sure. How much of the home kit Cologuard has penetrated the market of folks that are refractory to go to a traditional colonoscopy?
Yeah, that's a great question. So I don't have the answer to that, but I will say just from a personal perspective that I have seen a lot of marketing for the Cologuard, radio ads, I've seen some commercials on TV. And so, but I haven't heard or seen much from the FIT. And I'm not sure of the reasoning behind that, but I know that our research coordinators are also really involved in kind of working with that as well. So perhaps they might have some perspective.
Yeah, and I can see Pedro has his hand raised, so maybe you have some insight. I know you talked to a lot of people about when they order the screening through the clinical trial.
Yeah, absolutely. So with regards to Cologuard, functionally speaking, it's basically a FIT test because it is a stool test as well that you can do at home. The only difference is that it has a slight genetic marker added to it. But the difference in effectiveness when it comes to detection at an early stage is within 1%. So they have been studies after studies after studies that the FIT and the Cologuard are pretty similar in effectiveness. The difference in price, however, is that the Cologuard runs around $600 to $700, and the fit test will run you, between $25 and $70, somewhere along those lines. And then there's also the time frame. So the reason that Cologuard is advertised and the reason that everybody does prefer it is because you really have to do it only once every 3 years in order for you to be within the parameters of testing. You have to do a fit test every year. But if you think about it, like you said, from a market perspective, just not trying to do, I'm trying to think about only the money, but still from a functional perspective of a person, if the colonoscopy is the gold standard and it costs you around $1,200, and then it lasts 10 years, right? The Cologuard lasts 3 years, but it costs $600 to $700. And then the fit test costs $25 to $70, but lasts 1 year. As far as cost effectiveness goes, the Cologuard is the least cost effective, because for twice the money, you can get 3 times or 4 times the amount of time that you're cleared for, or for 10 times less money, you can just do it 3 times and you still be clear, just as good.
Right.
Again,
well, I was thinking about, the money for sure is important. I was thinking about breaking the barrier of prevention screening. The more Absolutely. Kids out there, availability, the more people may be inclined to do it at home. Obviously, when they look at the price, they will say, well, my insurance doesn't cover that, and I don't want to. So there's another reflection going on in the person taking the test. But the more out there, the more chance.
And it's a good thing that you brought that up. It's a good thing that you brought that up, because a lot of the times insurance will cover fit testing, but most people don't even know that it's an option for them. So, having that awareness is important. Right. At the end of the day, you can choose which test is best for you and your situation. If your insurance covers it, if you're, willing to go through the procedure, whichever one is best for you. But the real important thing is to actually get the screening done.
Sure, absolutely, right.
And just to kind of add to that too, I'm kind of starting to see more and more studies coming out that are looking at, the rates of looking at interventions that are dealing with the fit, and that are kind of, providing feedback on, rates of uptake and things of that nature. So, I think it's, something that we need to continue to, increase people's knowledge of. Again, that there are these other things that you can do, right? If you can't get to the clinic, or, if you have issues with, insurance, lacking insurance, not having enough insurance,
right,
and things of that nature. That so we are moving in, I think, in upward direction, but still lots of work, I think, continues to be needed for sure. So.
No, that's interesting. There's microbiome-based screening. So instead of, genetics, mammalian or blood, they look at configuration of microbes and predict different phases of cancer. So I know someone's going to come with a kit soon. So it'll be interesting to see the economy and the, frequency of screening, which is probably the fit is the always cheapest and fastest. And, for sophisticated kits, like probably the microbiome will come, may not be easy for people to get in.
And another thing that was really important during this time, we were in COVID-19 pandemic mode. Use of the at-home stool kit was beneficial, because it allowed people to still get screened, still be in, within the standards of colorectal screening, and have the ability to do it at home, right? And not be, address those concerns about being exposed to anything. You could still get screened.
That's a great point. I was reading the news this morning about breast cancer mammogram screening, 50% down during COVID. You can't do it at home.
Yeah.
Do it at home. You can but eventually you need more precision. So at the end of the day, that's right. These kits could cover a lot of need when you have hopefully never going to see a pandemic again, but you have the option to have it home, yes.
Yeah. And that was the beauty of our clinical trial, was that we were able to stay and recruit participants because of the nature of how we were sharing the information and educating people about screening methods for colorectal cancer.
Right. Yeah, those are really great points. And Pedro had mentioned the different years for the different tests, like within guidelines, but I don't know that we've mentioned the ages, the recommended ages for screening yet. And so I was wondering if anyone wanted to talk about those recommendations.
Yeah, I can touch base. I can touch on that really quick. So right now, the set standard recommendation that we're going by is 50 to 73, or 50 75. I'm sorry, but or 50 and up. But in my conversations with providers, there's actually some things in the works to try and have the standard lowered to 45. And the reasoning for that is because we're doing a better job in getting older people screened, right? So we're kind of seeing a little bit of a decrease there, but we're seeing younger people beginning to be diagnosed with colorectal cancer, and particularly between that 45 to 49 age range. So kind of those governing bodies that kind of oversee the insurance and what are the standard practices for the healthcare system, they are working on some things right now to kind of, going through that process of, lowering the age range that will be covered by insurance and things of that nature. So yeah, that's an excellent point, Melissa.
Yeah, and building up on that also, a lot of the population that does get the screening done, we're trying to catch it earlier in order to prevent the actual cancer from developing, because colorectal cancer, it's very treatable and very high likelihood of survival if you catch it early. But a lot of people that, don't get their screening done in time, or skip screenings, or, they don't catch it in time, that's when they run into the most trouble. So catching it earlier, it takes about 10 years to develop fully. But if you catch it at 45, instead of having to wait till you're 55, right? It's a lot better to treat it at 45 than at 55. So.
Yeah, that's a great point. And this might be a nice segue into our fourth segment, where we're talking a little bit. Pedro and Miriam, as research coordinators, they deal a lot with potential participants in research and with the community a lot. So we can transition into talking about some of the solutions and action items, and just kind of your experiences working on a really large clinical trial that engages a lot of people in the process of learning about and obtaining screening. So I'll turn it over to you guys for that segment of our talk.
Yeah, definitely. And I wanted to start this segment off by, basically giving a quick definition of a clinical trial according to the NIH, which is basically a research study in which one or more human subjects are prospectively assigned to one or more interventions, which may include, placebo or other controls, in order to evaluate the effects of those interventions on health-related biomedical or behavioral outcomes. So the reason I bring that up is because, when most people think of clinical trials, as from my experience as a research coordinator, speaking with the people that participate, the immediate fear is, I'm going to be poked with needles, I'm going to be prodded, it's going to be invasive, it's going to be something uncomfortable. And a lot of the research that is done out there, a lot of it can be just question based, just asking you questions like, hey, what were you doing during this time? Like, what was it like living in that area? Things like that, of that nature, like, can be very helpful in the field of research. So when it comes to recruiting, we try to be as broad spectrum as possible. So we try to do in-person recruitment to find people that are, live face-to-face. We do mail recruitment. We do over the phone recruitment, electronic recruitment via email, via the phone. So we try all the avenues available to gather the widest scope of people that we can for our research. So, the reason I bring that up also is because participation is, it's entirely voluntary. So when it comes to research, you can participate, you can choose to participate in it or choose to not to. Brings in the importance of participating in research, which is when you do participate, you become part of the group that basically led to the answers that the researchers found. So if the group is very homogeneous, meaning it only contains the same amount, the same type of people, or people from the same area, or only people from a same demographic, then the results are really going to be more biased towards that. So the more widespread amount of people that participate in research, the more widespread the results are and the more accurate they would be with regards to the general population. With regards to eligibility, really that's based on the study. So it's very study dependent. You can't really participate in every study. Some studies are for you, some studies are not. You know, the current study that we're doing, for example, you need to be between 50 and 73 because those are the ages of screening for colorectal cancer. So that's already a big, you know, thing. We don't take people that are 25, for example. And then also, as far as turnouts go, it's also willingness, based on the willingness of the person to participate. So if you ever get invited to studies and you know, don't wish to participate, still see that as an opportunity to maybe be interested in what's available. Look for, you know, what can be available for you and your specific needs and willingness to participate, like what things that you are willing to participate in. Because again, the barriers that we face as researchers, which, you know, Eric mentioned, you know, distance, accessibility, the knowledge of the availability of these studies, those are barriers that can be overcome from both ends. So us as researchers, you know, we're trying to break the wall from this end by trying to make it as available as possible for the participants. But if the participants work on the wall on this end by trying to willingly go out and look for research to participate in, then it makes the wall crumble so much easier, and then we can meet in the middle and get the results.
Yeah, and I'm going to add just a little bit to that too, Pedro. You know, meeting participant in the middle is quite an important task, and is quite a feat at times because we do have we encounter some challenges.
Absolutely.
With, you know, with participants. And one thing to consider is, you know, why people don't participate, why don't more people participate? It has a lot to do because sometimes fewer doctors who see patients also don't conduct clinical research. So it's not something that's readily accessible. Yes, I'm having a little bit of technical difficulties with my internet. So my camera just went off for a little bit, hoping I don't get frozen in time. So excuse me for that. Another reason is that there's different, people have difficulties finding the time or even having the resources to get to a clinical trial. Some patients don't, you know, may not even know where they can actually find where they can engage in studies. And so that creates another barrier when it comes to recruitment, because we as research coordinators may be focused on trying to find people for our studies, but if they don't know that there's an actual study in place, that becomes also a barrier of sorts. But when it comes to clinical studies and clinical trials, and looking at partnering with clinics and community, one thing to keep in mind that, you know, and I have several stats here, in 2012, only 17% of patients enrolled in industry-sponsored clinical trials. And of those, they were a member of a racial or ethnic minority group. So despite these groups making up about a third of the US population, you know, we still didn't see as many people. And this goes to, you know, what Eric had mentioned earlier, that, you know, we want to engage more diverse participants and include them in clinical trial research, because the results may have a wider applicability. So we might have more people. We want people that are older. We want people that are diverse, because different ages, sexes, races, ethnicities, that, you know, the more you involve that in the research and the more you involve similar groups of people, that you may identify, you know, what is applicable to some that may not be applicable to everyone. Another stats that I wanted to show was that in 2019, only 4% of participants in cancer drug clinical trials were Black. And that addresses the idea of the lack of diversity that we're tending to see in the clinical trials. So the great thing about our study, as far as our clinical trial in our screening, is that we are able to partner with other clinics and community. For example, I mentioned that some people don't know that there are studies, right? So there.
Oh, and I think we have a frozen Miriam, so we can
issue she mentioned. Oh, sorry.
Oh,
sorry, Miriam, you froze right when you were about to share, I think, the resources for how people can learn about screenings, you froze. So maybe if you could just start again and share what you were about to say.
Of course, of course. Apologies for that. So when it comes to resources, so a lot of the things that I mentioned before is we want a more diverse population. And so sometimes people don't know where to access some of these trials and where can they find them. And so one of the resources is the clinicaltrials.gov. It has a list of ongoing clinical trials, and people can search the studies based on the type of emphasis they want to focus on. The list also specifies who's eligible. And one thing to keep in mind is that you have to be accepted before you get to join the clinical trial. And these trials are not just for medical equipment or drugs, but they're also for behavioral intervention, which is what we've been talking about for the past few minutes. Another local and university resource that we use is HealthStreet. Obviously, they're sponsoring this this talk here, and HealthStreet, offers also ways for people to engage their community. We have used HealthStreet to help us with our participant pool. In addition to that, we also have CTSI. They have a recruitment center in their own community outreach engagement center via the UF Health Cancer Center. So those are different ways that people can find out, where can and I really want to be part of a study. I really want to be part of something big and make a difference in research and maybe become, a partner in a scientific discovery. And these are ways that you can engage in. Besides the fact, I know Eric is going to talk about our study, some of the things that, eligibility requirements that we have for the study.
Yeah. And Miriam, is the lack of, I'm not sure if I understand. So is it lack of awareness that there's clinical trial that could be, that these folks could participate, or is it a lack of trust of, from participant toward medicine? What is it? If there's one.
Both, I would say, because one of them being, the first one, let me address the first one. Some people really don't know what is a clinical trial, right? And they don't even know, if they don't know what a clinical trial is, they will not even know where to find one to participate. The second is, the trust factor. Some people, there's history shows that participants have had bad situations, right, with some studies. And so building trust is critical for participation. And that's where Pedro and I come into play. When we talk with our participants, we try to engage with them and communicate with them and just impart that trust factor and let them know the functionality, the process. If they have questions that they can come to us, ask us. The beauty of our institutions now is that we have an institutional review board, which addresses those, it's an ethic committee and addresses those concerns that people may have. And so when Pedro and I talk to participants, we often, if not always, right, let them know that IRB their function in how they're there to not only help the participants understand, but also help the researchers engage in their studies, right? So,
thanks.
Those were great questions.
Yeah. And, you know, I mean, I didn't want to bring this back to the you know, economics of things, so that we talked about that already on one aspect of the screening. Participating in clinical trials usually does involve compensation for your time. So if the barrier is thinking that this is a waste of time and I'm not getting anything for this, that's usually not correct. There's usually some sort of compensation for your time and participation.
Yeah, that's a great point. And Eric, it looked like you wanted to jump in.
Yeah. Well, I was just going to wrap us up really quick. So if everybody's questions got covered, I was just going to, you know, tie a quick bow on it by talking a little bit about our particular study that Miriam and Pedro have mentioned. So over the course of this talk today, we've talked a lot about barriers and in getting screened among minority populations, and we've also talked about some solutions, right? So one other example of a solution is the use of virtual human technology to provide tailored patient education and to provide information about screening opportunities, the different screening options. So an example of the use of virtual human technology is the Meet Alex clinical trial that's currently underway here at UF. And from the visual, you can see the four examples of this virtual human technology, right? So in this project, patients interact with a virtual physician named Alex who discusses colorectal cancer and talks about screening. And at the end of this virtual interaction, patients that are interested in screening can begin this process and this conversation with their doctor. So if you are between the ages of 50 and 73, or you know someone who is, and you would like more information about this study, you can contact us at the information listed on the slide. So we have a really great team of folks, and we would love to work with you. So overall, just a final statement for me anyway. So kind of interacting with the virtual physicians, you know, is a different way of engaging with the medical system for patients, right? So what we really want to do is we want to stimulate people's willingness and interest in participating in something like this, and also continuing to raise the profile of, yes, it's very important to get screened, right? So one of the things that really raised people's awareness over the past year was the death of Chadwick Boseman, the lead actor from the Black Panther. So that really hit a lot of people hard to see somebody so young and you know, full of life to die so early from colorectal cancer. So there is an increasing level of you know, knowledge and people really kind of looking at this like, hey, I need to get screened too. So now we just want to kind of motivate and encourage and provide opportunities for people to go out and get screened. So with that, as we can.
Yeah,
Melissa,
well, thank you for sharing that. And Eric, how long will the study be open so people can contact you over the next couple of weeks, months, if they are interested in participating? Yeah, we are open for business for the foreseeable future. So yeah, anybody that's interested, feel free to reach out and we can.
Currently the recruitment is up until December 31st of this year. Now, so.
Great.
And in addition, we are recruiting from all the UF health clinics, and we're in Jacksonville as well as Gainesville. So yes, any questions about the study, please give us a call.
Great. Well, I think we are right at the 1 hour mark. So I've really enjoyed kind of learning and listening, even though I work with most of you every day, like hearing your unique perspective on what you do, and in conversation with Dr. Jobin also was really fun, and I hope was helpful to others who are interested in learning about how to engage in colorectal cancer research and learn about how they can just engage with their own health behaviors and screen as well. So thank you to, this concludes Our Community, Our Health Town Hall. thank you for joining us, and thanks to all the panelists.
Thank you for sharing all this. That was a great job. Thank you.
Having us.
It was fun.
Thank you all.